measles and tuberculosis. So just as you heard, this meeting is being recorded. Any additional recording, like AI, is not permitted for this session. So we do offer CMEs, and we offer one credit for CME, as well as for Illinois registered nurse relicensure. You could claim credits for that. I do hear a live mic, so if you can make sure everyone else is muted, that would be great. The only other thing to just know that those who are, David, can you mute others? I think I hear a live mic on there.
I got it.
So participants claiming CME, please make sure you answer the questions. We'll keep the link live for about 1 week after this practice session, and it'll be emailed to you too. Pleased to disclose, none of our presenters, including myself, have any financial disclosures. And what we'll do today is really go into some clarifications for recent practice advisories we've issued on measles, give you a situational update, as well as provide you information on new toolkits we have for clinicians on vaccination assessment, testing, and reporting of measles. Then we're going to go into increasing awareness for what's going on with TB and what IDPH does to mitigate TB in Illinois. And finally, spotlight the Lake County Health Department and some amazing work that they've done, especially when they had a very sensitive situation of a TB exposure in a high school very recently. So I'm going to moderate the session. For those who do not know me, I'm Aarti Vanch, Chief Medical Officer at IDPH, and my unofficial disclosure is that I do speak very fast, so mea culpa, and I apologize ahead of time. I'll try to slow down as much as possible. Just for a good practice, please use the Q&A box. It's in the 3 dots to the lower right of your screen to put in your questions if you want to ask a question live. We do have a little bit of time built in towards the end of the session where you could ask your questions live, but that's going to be saved for the end. And I'd love to introduce our section chief, Phil Wagner, who will talk about the Illinois TB program. And that is going to be followed by Tom Moore, who is the TB program coordinator for the Lake County Health Department. All right, so let's talk measles first. What's going on? We've got over 1,000 cases in just 5 months in the US. And this is unprecedented. We've had multiple jurisdictions, over 30 involved, 14 active outbreaks in the nation, and Illinois is now one of those 14. And it takes 3 linked cases, like they have to be linked to each other to really be considered an outbreak. This is the critical thing I do want people to pay attention to. Though 13% of the people with measles ended up in the hospital in our 2025 situation. But if you hone in on the children, that's almost over 1 in 4, 1 in 5 children is getting admitted to the hospital with measles. This is not your common cold. It's serious, and we really need to think about what we can do about it. 2 out of the 3 people who died were children. So I really want to make sure everything is done. We leave no stone unturned in what we can do here. In Illinois, we're holding out at 8 cases. And this is important to know. Thankfully, no hospitalizations. These are all adult cases. We are in an outbreak situation in Franklin Williamson, but reassuringly, thanks to some amazing work by the local health departments, we are not really seeing the same degree of expansion, explosion, I should say, of cases as in other jurisdictions. And I'm very proud of our team and our local health department for the work that's going on there. So what do clinicians need to know? Please, if someone's walking to your office and it looks like measles, smells like measles, we've had some very big exposure locations in airports, gas stations, restaurants. It's important, just know what those are. Ask your patients, not just have you traveled to Texas or New Mexico, but have you traveled, when were you at O'Hare at this time? We have these available on our website. So I think it's important for clinicians to know that this is available, and it's an important piece of information to elicit, to make you decide, does my patient need testing or not? If you decide this patient needs testing, you can do it at IDPH. Well, send the lab to IDPH, I should clarify. So both our Springfield and our Chicago labs run measles testing. We prefer to be the ones doing the measles testing because we've noticed significant delays through commercial for us to get the results from commercial labs. But if it's a low risk situation, the public health system doesn't even think this is would meet criteria for testing, but you feel that this person still needs testing, you can then in low risk situations send it to a commercial lab. But this is the process. If you think this person needs testing, call your local health department, collect the samples, but call them because they will give you an authorization code. And that authorization code will need to be submitted with the lab requisition when it goes in to IDPH or when we get it to IDPH. And just another very cool bit of work that our lab is doing is that we can test for measles vaccine strain in-house now. So if some people have a mild vaccine reaction and they get a rash and you're not sure is this measles or just a vaccine reaction, which is not contagious, we can run that testing, and I'll go into who really would warrant MEVA testing in a bit. So this is key. We have had providers call us 1 week after someone's walked out of their door. They were waiting for serology results, and it took them a week. Even for suspect cases, you don't need to wait for a positive result. If you suspect measles, you have 3 hours to call us. Don't wait. You don't need to wait for confirmation. If you suspect it, call your local health department. There is an online registry. Most know how their local health department contact information, but if you don't and cannot get hold of them, we're the backup. You can call us too. So one important thing, do not forget to ask key history. You are the only point of contact often for days before we can get hold of the people, because they leave your ER or your urgent care or your school, and then when the local health department tries to call them later, they may not even take the call. So find out, not just details of the rash, but the vaccine status, the travel exposure status, but more importantly, who's in their household. You are sending someone with potential measles back home to isolate and quarantine at home, and potentially their household contacts will need quarantine. What's the immunization status of their household contacts? Do they have a pregnant person? Do they have a child less than 1 year old? Do they have someone who's very immunosuppressed in their household? Before you send someone back with measles to their home, get that information. And I'm going to go into post-exposure prophylaxis. This is going to be an important consideration for that too. So this chart is also available on our website. It gives you a nice timeline of where do you think this person is from the time of their exposure to their rash onset. And most of you, again, understand that, are aware that it's 4 days before and 4 days after the rash that you're considered infectious. So cases are less infectious or have to be in isolation for a much shorter duration of time, because by the time they get to you, they're already in a state of rash. Then they're exposed contacts who are not immune. They have to be in quarantine for 21 days. But the key thing to know is make sure you tell your patient to self-isolate for 4 days, at least after the rash onset. And don't use that patient's room, especially it's unlikely they will be in a negative pressure AIR room. So you really want to make sure there are enough air exchanges. Don't use that room for at least about 2 hours after, and report suspect cases immediately. This is a new toolkit that we adapted from the CDC's toolkit to make it more relevant to the Illinois context. And this really walks you through how to think through who needs to be assessed for testing. And not every scenario will be captured in this, so always call the local health department if there's a scenario that's not captured in this. David, if you can put the straw poll in. I'm going to do a little straw poll to see if people can understand this algorithm while I go through it. Let's say someone walks in, they have a fever, but their rash looks really vesicular. At that point, you're thinking, if it's truly vesicular in nature, very unlikely to be measles. But if it's not, ask the question, is there any risk for measles? Have they been around someone who may have been exposed? Most of our cases, we're never able to ascertain any exposure risks. So let's assume you don't know, they know exposure risk. Then the next question is, what do they have fever plus rash and one of the 3 C's? So it doesn't have to be all 3 C's at once, one of the 3 C's at least, either cough or runny nose or conjunctivitis. And if so, thinking, could this be a measles vaccine reaction? Yes, no? Only if they've really had the MMR for the last 21 days. And often if they've had it that recently, the question is, were they exposed, or is this just like a 12-month-old baby who had their standard MMR? Very few, only less than 5% who get the MMR will actually get a measles-like rash. And again, that is not contagious. So maybe if you think they got the rash, but they've been exposed, I still want to check if this is a breakthrough infection, or is this a vaccine reaction? That may be the person that we could flag for MEVA testing. Vaccination history is key. I just got a call on a baby who was 15 months old, but I couldn't tell, had one MMR, but I couldn't tell if they were in a daycare or not. So if the breakthrough infections with one MMR can still occur if the exposure is intense, like in the household or in daycare. And so I proved testing for this kid, but one of our early cases, even in 2025 in Illinois, was an adult who had one MMR, over 20 years ago. Good news is the infections are pretty mild, even when you have that one MMR, and your symptoms last for a very short time. So there is some reassurance there, but this is how I'd like people to think through the algorithm. And again, take your time to answer the straw poll. We'll go into the results of that right after the whole session's over, during the Q&A. And as I said, it looks like most haven't answered, but a majority I see are answering in the direction I expected. So that's good news. All right, we're going to, since most haven't answered, we'll keep the poll open and keep going to the next slide if I can. All right, so this we've included in the Clinician mini toolkit. Sorry, I think can everyone still see the slides? All right, so we've seen I've also included in the Clinician mini toolkit additional considerations. What you would need to know if someone is self-reporting a fever, is that enough? And the answer is yes. I think you don't need to have a quantified fever in the hospital to make, or in the healthcare facility to make that diagnosis. All right. One question, fun flag for clinicians. If it is not measles, what is it? So if you hinge your only test on that measles test, and thankfully pretty much all the testing we've done this past week has been negative, which is good. But then the question is, what caused that rash? So if you still need to know for the purposes of school or work exclusion, then consider these on the differential and consider whether testing for these is warranted, not at the IDPH lab, but at other labs. And common drugs, amoxicillin, Flagyl sometimes can also cause drug rashes that can look like measles. So one key message from this slide, I'm not going to go over most of this information again, because we have instructions for measles virus submission. These live links are available on our website and will be sent out to everyone here, so you'll be able to click on them. We'll take an oropharyngeal as well as an NP swab, but serology is nice. It's useful to not use it to rule out measles diagnosis. Now, this is one key thing. We have gotten specimens way too often we can do nothing with. They come to us at room temperature. So why does that matter to the clinician on the front line? That means you have to make a phone call to your patient saying, come back for another retest. You might need to stay in isolation longer because I don't know what these results are. So if you have any power to make sure you can influence the processes, make sure that these are sent to us cold, in cold packs. It cannot get to us at room temperature. Don't just drop your specimen in a box will be staying at room temperature for hours and hours. So if you can do your due diligence, it will really expedite diagnosis and less time that someone might need to be in isolation or have the burden of being brought back for another visit and retesting. So what do you do once you say, okay, I suspect this is measles? What happens to their contacts? Now, we don't expect clinicians to contact trace, but we want you to give the right advice to your patients before they walk out. And this is that their close contacts, especially the ones who are not immune. If you've had 2 doses of MMR, you're good. Even if you've had 1 dose of MMR and you're not a healthcare worker, you don't need quarantine. But the others should get an MMR within 72 hours of the exposure. If they can get it within that window, those who are not immune, they don't need quarantine either. And yes, you can give it to household contacts if someone in that household is immunosuppressed. There's no secondary transmission of this measles-like virus to immunosuppressed households, so it's safe. Now, the immunoglobulin we conserve for our children, infants, pregnant people, and immunosuppressed. So if you're a healthy adult who missed that 72-hour window for PEP, you're not going to get immunoglobulin for the most part. It is really conserved for those who really are truly vulnerable, have no other choice. The window is larger, 6 days, but it's also important to know that you might have even a longer incubation period, like quarantine period, about 28 days sometimes with the immunoglobulin, and you might have to wait 6 months before you get the vaccine. Now, this is very effective, 90 to 100% effective. And I want people to remember that when measles hit Chicago in 2024 and the Chicago area, in an explosive shelter-like situation, we maxed out at 67 cases, more because of some heroic efforts in getting mass vaccinations, mass post-exposure prophylaxis to all the exposed contacts. This works. We just need to get it on time. Now, IDPH does not stockpile immunoglobulin, so we did send a survey out to healthcare facilities. We expect healthcare facilities to take stock of what immunoglobulin they have, and we've launched a survey. On the right, you'll also just see a rubric of how to think through who really needs MMR versus immunoglobulin. And please make sure if you or anyone in your facility got that survey that they answer it. We will try to help facilitate access to where this product is located if needed. Now, let's go a little bit into not just the exposed contacts and cases, but the general population. People are going to ask you, do I need extra shots because measles is in the air? The recommendations are, if you haven't had what you already need, get what you need right now. Don't wait a minute. But for young infants, for example, the ones who are 6 to 11 months of age, the standing recommendation has always been if you travel internationally because of measles risk. But what if you're traveling to a domestic outbreak area? ACIP still recommends that these children can get it if there is ongoing exposure. But the key thing to remember about this ongoing exposure is that how do you counsel your patients about risk versus benefit of this tender age, the 6 to 11 month age? And the reason this dose doesn't count, and they say you need to still get your regular doses, is because children's immune systems are still building and burgeoning, and we don't know if they will truly respond as well. There's one study from Netherlands where they followed kids after they got their, infant, like this, I would say dose 0 for 6 years, and they found out about 70% of them lost the antibody as measured in the lab after about 6 years if they got that extra dose early. So they think maybe you're not holding on to lab antibodies as much, but a third of them do hold on to those antibodies. But we don't know, does a measurement of no antibody in the lab after you've gotten this equate to you not being able to respond to measles? And if people want to know more, we can talk about why some of these theories are about whether, a third or 2/3 of these kids may not be able to have demonstrable antibody 6 years after they've gotten this additional dose. And that's the conversation to have. Does it hurt? No. And in a situation of outbreak, they need the protection now. So, but this is the risk benefit discussion you can have with your patients about that 6 to 11 month dose. Another thing that could be a helpful reference for clinicians is really talking about what's the risk with a live vaccine like MMR versus the actual measles infection. And there are some quantified risks. febrile seizures and ITP. Febrile seizures, not really, it's very low, 1 in like 1,500 to 1,700 doses, and more with the measles MMR and varicella, the MMRV rather than an MMR. The ITP, while it's quantified, it's really no higher than the general incidence. But no, they don't get brain infection or brain inflammation with the vaccine. They don't get autism with the vaccine. And that is our position on this as of this point in time. So the question to clinicians, are you prepared? There is this checklist. Please make sure you, as your healthcare facility, is prepared for measles to walk through your door right now. It's everywhere. It's important to be prepared. And this is one survey we did for schools, and especially the schools that hadn't had a great vaccine rate. And one of their plan, a third of them plan to reach out to their local healthcare providers to help them with vaccinations. So when your school reaches out to you, or if they do, please be prepared and try to help them out. And if you don't have the ability or the capacity to help them out, IDPH does have a service now for the next couple of months to be able to bolster that. So we're really hoping that if you feel your school's reached out, or you feel there's a need in your community, reach out to your local health department and we can arrange for some mobile vaccine services. And with that, I just want to remind you, get prepared. Here are all our toolkits. I sincerely hope they're helpful, and give us feedback if you think we need to tweak them in a different direction. And I just want to acknowledge our fantastic team, our immunizations team, our communicable disease team, our lab team, and our clinical advisor team in both putting all this material together and trying to get the message out there to the clinicians. So we also have signage you can use. And so with that, I'm going to pause. I'll answer questions in chat, and I'll hand it over to Phil Wagner, our TB section chief. And I think you hear a question about the slide, the resources. We'll be sending out this to every single registrant. You'll have a copy of the slides. So Phil, if you're speaking, we cannot hear you.
I'll unmute first before I share, because it somehow didn't work. And now I got to go find my presentation. Somewhere. All right, here I am. All right, I will share. I will share my presentation. It's not sharing my right. Oh. All right. Can you see my presentation? No. Some reason
yes, we can see it now. We can see it now.
Sorry about that. All right. You see the full view, hopefully. Anyway, will this work for you?
Yeah, Phil, I think if you want to make it whole screen, then I think the font will be
there.
Okay, that's fine.
All right. So a little bit about the TB program, just what we do. But these are all the things we do. It's one of the questions that you need to answer. So we report and do surveillance, of course. We provide technical assistance to local jurisdictions. We do supply medication for patients that qualify, low income and those in need of LTBI treatment. We can supply. We do support local counties through a grant program called a DOT grant program. It's a pre-selected number of counties, and application is already over for this following year. but we will extend it in the coming years. And this is for local counties' capacity to do directly observed therapy and support TB patients. We do have a laboratory, so we provide laboratory services and provide education and training. So a little bit about the surveillance. This is our TB cases and rate up to 2024. We pretty much stayed steady. We have the highest number and the highest rate for the whole Midwest. So just keep that in mind. Like TB, like measles, is still around. It hasn't been eliminated. And I'll say even people die from TB. So we have about 4% of our cases actually die every year on average. So it's still a killer and a serious disease to pay attention to. We are without a TB epidemiologist, so I'm doing the epidemiology now, but hopefully we'll get an epidemiologist soon. We provide technical assistance. So we provide assistance about nurse case management. We have 3 regions where we each have a designated TB nurse. We're short 1 nurse right now, but this is for local counties and for providers, anyone, to contact us about case management. We have recommendations on isolation. We provide help with treatment monitoring. We also facilitate any medical clinical consultancies with our centers of excellence, and ours is in Florida right now. We do provide TB surveillance, educate and do training, and also consult on any contact investigations or elimination strategies. Other assistance, we do have the program for grants that is called the DOTS program. It's a comprehensive health protection grants going out to the counties, and the DOT one is just part of that. We do also provide the medication, like I said, it's called a 340B medication program. It is a federal program. I hope it continues, knowing the current state of things in our country, but so far so good. We can help anybody with symptoms of TB, X-ray interpretation, blood test interpretation, any kind of laboratory, sputum collection, all these things we're experienced with, so we can provide any kind of assistance you might need. And there are, technical areas of quantiferons and gene experts that do PCR testing and the old skin test, as well as drug sensitivity testing. We do have 3 laboratories, and our main laboratory is in the Chicago area, and we do provide sputum smears and cultures, which is on the bottom of the BACTEC machine. We also have Gene Expert that can do a PCR, rapid PCR, and do mutation for RPOB, which is for the resistance of rifamycins. We also do a DST, drug sensitivity testing. Now we have limits on that, and if you want rapid testing, you can send us an aliquot or a bit of the sample, which is required by law to send the culture to the state lab. We can facilitate by sending to the Southeast National TB Center for Sangar sequencing. We can look at all kinds of mutations and see what kind of second-line drugs that they may be sensitive to, or to the CDC for MDDR, molecular detection of drug resistance. We do provide training and education. We do have 3 regional conferences every year. We have set visits and program visits that we'll be doing for the coming years with our new grant for CDC. We do have courses, and the centers of excellence have courses that are online on nurse case management, contact investigation. There's a TB intensive course in person at all the centers. There's a center in New Jersey, a center in California, a center in Minnesota, and a center in Florida. We also have the ability to do mini fellowships, and we will be providing some scholarships for that over the coming years to send a clinician in person to one of the centers, and ours will be Florida, to actually see and follow a great clinicians around and see what they do with TB. There are many archived courses on these centers that you can look at, and eventually, hopefully, we'll have some on our own webpage. We're working on that now. And in the future, we hope to have more webinars, not only on World TB Day, but on special subjects and on state updates. And that was it. I must say that our next speaker and I have known each other for more than 25 years, because 25 years ago, we worked together in Turkmenistan on a Doctors Without Borders TB program. So thank you.
Okay, so should I jump right in?
Sure.
Let's see. My view has changed. Can you see my slides?
Yeah, we can see it. Do you want to, yeah.
Okay.
Yeah, go for it.
Good,
Yeah.
and that's the proper view. Okay, so today I'll talk briefly about mitigating TB risk. I'll focus on a school close contact investigation that's actually still ongoing. Yesterday, we finished 2 days of testing of students and teachers from that school. Now let's see, my slide didn't move. Okay. Okay, there we go. So we'll start out latent TB infection. It's asymptomatic, it's non-infectious, it can progress to active TB. It's estimated that 25% of the global population actually is infected with TB, so they have latent tuberculosis, but most of them don't develop TB, only about 5%, even 5 to 10%. Even with those low numbers, in the United States, CDC estimates that 80% of our cases are coming from long-standing individuals with long-standing latent TB infection. So latent TB should be considered for preventive therapy if we want to eliminate TB, which is one of the global goals. And close contact investigations are crucial to mitigate the potential for more active cases. Okay, I'm speaking from Lake County today. We're located in the northeastern corner of the state. We border Wisconsin in the north, Lake Michigan in the east, and Cook County in the south. We have a population of about 700,000 people. The Lake County Health Department is a large health department. We have over 800 employees and 12 facilities. The tuberculosis clinic where I work is just one of those facilities. Now, although this slide, it depicts from 2017 to 2024, I would note that essentially TB rates in the United States have been dropping since the early 1970s, except in the late 80s to 1993, where it rose due to the HIV epidemic. 1993 was the peak of that spike. Rates continued to drop again until COVID. And then during COVID, TB rates increased in Lake County and Illinois and the United States, and they've increased globally. They've started to stabilize a little bit. But during COVID, between 2021 and 2022, Lake County saw a 128% increase in cases. During that time, COVID became the top killer for an infectious disease, but TB has taken back its place since 2023, which it had held prior to COVID and for a long time prior to that. Okay, in 2024, we had 18 active cases of TB in Lake County. It's an estimated incidence of 2.5. Our 5-year average has been 14 cases. In 2024, 89% of our active cases were born in outside of the United States, but 75% of those, or 12, had lived in the U.S. for over 5 years. So that's not like our active cases are just coming from newly arrived immigrants. I should note that CDC also estimates that there are 13 million residents of the United States that have latent tuberculosis. For our active cases, the most common countries of origin are Mexico, Philippines, and India. That was last year, but it's been like that in previous years as well. Lake County has an interesting history of tuberculosis. In 1904, there was a doctor, a 29-year-old doctor, Dr. Watterson. He was diagnosed with tuberculosis. There was no tuberculosis treatment available in Lake County. His doctor friends told him to go try to seek care elsewhere, not expecting to see him again. He left Lake County, ended up in Denver, and he recovered. He returned back to Lake County in 1907, and he started up the first TB sanitarium in 1908. It was called the Lake Breeze Sanitarium, which is essentially cottages and tents where TB patients got fresh air and a good diet. There were no drugs until the 1950s, so that's what treatment was. In 1936, a tax levy was started, and with that tax levy and federal funding, Lake County was able to build a 90-bed TB sanitarium. It was, that sanitarium was honored in 1944 by the New York Museum of Metropolitan Art as being one of the best examples of architecture in the country and a state-of-the-art facility. I should note, when they opened the facility, one of the speakers noted that in 1938, the United States had had over 69,000 deaths due to tuberculosis. The latest CDC data in 2022, we had 565 deaths. So you can see the epidemiological situation has changed drastically. And provisional data from last year, the 2024, said we had about 10,300 cases, a little bit. Okay, so in a close contact investigation, our primary objective was to identify and screen all close contacts. The CDC target for screening of close contacts is 90%. Of course, we started with family and close companions. There were 4 household members, 4 close companions, but that individual had been at a local high school for about 5 weeks while they may have been infectious. So we identified 156 possible close contacts, 8 staff, and 148 students. I won't go into too much detail on this slide. It's just that when this case was identified, we immediately started having internal meetings about what we were going to do because we knew there was prolonged exposure potentially at the school. We reached out to the school. We started preparing letters to send to the identified close contacts and to plan what kind of events we would do to follow up those close contacts. Now, we didn't want to send anything out until we had the bacteriological confirmation. As I said, that came on the 25th. This was spring break. So the school actually didn't distribute the letters notifying close contacts until the 28th, which was a Friday. When they were notified notified by email. The email included links so that families could schedule themselves for testing. The school didn't want testing done on site, so we had to come up with an alternative site. That site was at the Lake County Health Department. We had a room to do the testing. This is the setup of the room. The patients entered, they were registered. We sent the lab orders. Then they were given a questionnaire, red cap questionnaire about their risk factors, and they were tested. In 2 days of testing, we tested 101 patients there, scheduled others. And one of the key things was that we wanted to make sure we had enough testing staff. We initially started with 15. We realized shortly thereafter that was too many. So within an hour, we started reducing our staff. And for the second event, which was conducted the last 2 days, we had 6 to 8 staff on hand throughout the day. So that was enough for us. After the first round of testing, well, from the family members, we were able to test 3 of the 4. One had left. He had been visiting from out of state. They were lost to follow-up. They all were positive. One we had previously treated. We checked that person again. They were still okay. Everyone else in the family has initiated treatment. For those that were tested on site for us, we were able to reach 146. We weren't able to reach 9. We had 7 positive quantiferon tests. That was a 4.8% positivity rate. 2 of those were recent conversions, but all of those 7 had risk factors, so we couldn't tie those conversions necessarily to our index case. So we were able to test 94.2% of the close contacts in the first round of testing. So we exceeded the CDC goal. We wanted to get 100%, and we're still working on that. Of our positive cases, 6 of the 7 have started their preventive therapy, and the other 1 canceled their appointment, but we anticipate they also will start their therapy next time we have an appointment with them. Okay, for the TB case management, our index case is doing very well. They've gained weight. They don't have any more cough or symptoms. They've complied with medications. We do video dots, so we observe all intake of medications. Their sputum smears converted to negative after 2 weeks of treatment, and they were removed from respiratory isolation on the 18th of April. So 4 weeks after treatment initiation. As I said, they were pan-sensitive, so we're not worried about the regimen. So challenges in the process of doing the close contact investigation with the school. Because we weren't able to test at the school, which we had wanted to do, we had to have an alternative location that was during the workday, during school days. We made accommodations, and the school made accommodations, so students could come with proxies as well as the parents. I should note there was a very short period of notice between when the school sent out letters to the close contact, which was on the 28th of March, and then the testing dates, which were April 2nd and 3rd. So not many parents had used the link to schedule appointments. So on Monday, the 31st of March, we had a team of people calling all of the students and family to schedule them. And that was very successful, the direct outreach. We did have 8 no-shows. As I mentioned, we're still trying to capture, more than the 97% that we got in the first testing. We overstaffed for the first event, but that allowed us flexibility to send staff back to work and make sure we had enough people on site to be able to handle the ebbs and flows of the students coming in for testing. In summary, I think the intervention highlights the work that was done by the local TB control authority, but it wasn't just us, it was the health department. It's a resource intensive and labor intensive activity, and it was time sensitive because we had to coordinate the 2 events. In the process, we found stigma and concern from the community, even from some of our partners and people within the health department, because TB now is a low incidence, or US is a low incidence country. People don't know a lot about TB, and they were afraid about that. Even we had to have discussions with our lab partners about concerns for infection control for the on-site testing. Then I would highlight that it was very important, the collaboration that we had. It was not just the TB clinic here, but our SCI department, our emergency response team, our immunizations team, who had worked on COVID and monkeypox, that had run kind of events like this, were essential. Coordinating communications between the communications teams with the health department and the school district were very important to make sure we got the right messaging out to the community. So all of that coordination, including with the high school, it was key, and it took a lot of patience. And it's still ongoing. Like I said, we tested 89 people yesterday and the day before. We have 21 more scheduled, so we'll still be following up an additional 39 and those 21 until we get their tests. So it's an ongoing situation, and hopefully we'll get that second round of testing and be over 90%, again, reaching those close contacts. So that's what I have. Thank you.
Thank you, Tom. And I will share back for just the last bit of the housekeeping, so to speak. Right. And there are some great questions in the chat, so I'm just going to open those up too, and I'm just going to show, apologies, that was not what I intended. I'm also going to make sure that these slides with the live links in them get to those who have attended as well as registered. There is a live link to register for the next 2 sessions. We're going to talk about tick and vector-borne disease, and also, again, the back to school children's health agenda in July as kids get back to school in August. And you know, we are also going to part of the vector-borne disease prevention will also include guidance for how to think through summer safety. If you need to reach out to anyone in the medical services division, you can use this QR code or send it. We have a messaging portal that'll get to our medical advisors, but please sign up for Siren. Our health advisories and updates, including updates on outbreaks or emerging situations, are sent through our Siren system. If you haven't already, please sign up for our Siren system. And finally, those who wish to claim CME, this is the QR code. David, could you drop the link in chat too for everyone to see? And then I'll take this link. I'll hover over here for a minute in case those want to use the QR code, but please know this will be live for about a week. So you could claim CME at that point. All right. And with that, I will open it up for any questions. I know there are lots of questions in the chat on measles immunity and what happens with low titer. So just to frame it now, if you're an adult, you had either you're in a known, like documented measles vaccine, measles infection, natural infection, you're considered protected for life. If you've had all your recommended doses of your vaccine, that means the first dose has had to have occurred after 12 months of age, and the second dose can occur anytime 28 days later. Now, there's some nuances there, but traditionally we recommend the second dose for kids when they're 4 to 6 years old. But if you think your kid's going to travel, or your a kid might be exposed. I got my daughter vaccinated early. I didn't wait for her to turn 4. That second dose is still counted for the school requirements. So if you have those 2 doses of vaccine, even if you years down the line you check and you don't have titers that can be measured in the lab, the idea is that you have memory T cells, a memory response. Your body finds a way to remember how to fight measles. But if, say, you don't know if you've been vaccinated and you don't have a positive titer, you can just go ahead and get yourself a vaccine or catch up to a vaccine. So it's make sure you got all the doses you need. That's 2 doses. 93% protection with 1 dose, 97% protection with 2 doses. Remember, it's not 100%, but people who get breakthrough infections, often the infections are mild and can be considered atypical, or more, I would say, modified measles. It's really not very strong in its symptoms. All right, let me see if there are any other links between TB and measles other than just overall weakened immune system. No, so I think the question was more, for example, if someone who has latent TB and is fully vaccinated for measles, would they be more likely to develop breakthrough measles? No, there's not that much of a risk, like if someone has latent TB, that they would be more at risk for getting measles. So that's a good news on that front. But you wanna, again, sometimes the question about measles is more like if there are people who come from countries where they get BCG vaccine, which is another live vaccine. Often you will like space out live vaccinations, but I'm opening it up to also my TB colleagues to see if they have anything else to say about any connection between TB and measles.
There is none that I know of. And I don't know if it's well studied at all. The biggest things for TB are much more immunological, cancers, kidney disease. These things really will impact latent TB and make it active.
Okay, great. And Phil, we have a question for you too in the chat. They were told that they no longer test TB by injection, which I'm assuming means the skin test, only by blood test. Is that a preference or a standard requirement now?
CDC says either one is good. The preferred is the blood test, but there are issues testing low risk people with the blood test. We have the skin test is cheaper, but you have to come back and get it read. We know we have more than 150 years of experience with the skin test, and we know it quite well, but it's not so specific. It can be any mycobacterium can show up as a positive. So preferred is blood test. If you can do it and you send people there, especially for anyone born outside the United States, because the BCG vaccination will impact the skin test. It does wane over time, but there's different vaccines in different parts of the world, and some wane, some don't. So blood test and skin test, but blood test preferred.
Pros and cons of each, as Phil was discussing. It looks like there's a problem with the QR code, so we will fix that. And the link that we send out, or the presentation we send out, will have the appropriate QR code and link. So apologies that the QR code is not linking to the right CME form. Is there, and the next question, is there a difference between German measles and red measles? By that, I'm assuming you mean regular measles. Yeah, different virus. So German measles is rubella. So measles, mumps, rubella. So German measles is the R in the MMR. And it's more, you see more what they call congenital rubella syndrome. So it's even scarier for pregnant people who get natural infection with rubella. So yeah, there is a different virus. They often present very same. We don't see much rubella much at all anymore. We are still sometimes seeing mumps outbreaks, not thankfully as much in the US, but we again very grateful for the fact that overall in Illinois we still have great vaccinations. The sad part is our vaccination rates have been going down over the past 5 years, and we're, especially in school kids, and we're sort of at the age where we're at the threshold where we're reaching not as much herd immunity, less than 95% herd immunity, or hovering at that critical zone for our children for MMR. So that includes measles, mumps, and rubella, which is German measles. Right. Any other questions? If people would like to come off mute and ask their questions, I don't know if Mike or David, we could facilitate that, or else you could put it in the chat and I will ask it live. Is there other questions we may have missed? Oh, there's one in chat. I feel there's some questions popping up in chat. If you can use the Q&A, that'll be helpful. I believe the newest CDC requirements suggest routine PPD testing is not needed for community nursing for example, on hire? Does IDPH have updated requirements on routine PPD testing for new hires? Our agency is currently testing upon hire and annually. Oh.
Yeah, there's 3 guidelines for actually testing healthcare workers. Either test is still okay, so that's the same. In terms of baseline testing is required, annual testing is no longer recommended. There is a caveat in the old 2005 guidelines. If you're a nurse, you're working in public health or in a facility, and you've had 2 documented negative skin tests, you don't need another baseline test, a 2-step test. You only need a 1-step test if you go into another facility. Now, private sector agencies and facilities can always do more. So be aware of what they require, like a nursing home or such. Yeah, annual testing, baseline testing, you can do either test. That's still in effect.
All right, and we're down to our last minute. I just want to say thank you again to everyone who took the time to join us during their lunch hour. So appreciate it. And, hearing or seeing no more questions. If there are any questions we didn't get to, we'll, try to see if we can connect with the people, or just you can send us, once you get the link, you'll also be able to just send us questions if you have any concerns. We will figure out the QR code and link, and apologize for the situation with that. And we'll send out the right QR code and link when you get a copy of the slides after this. Right. Thanks, everyone. Take care. Bye.